Well, welcome everybody to the ICMDA webinar. This is our third of the series. I'm Dr. Peter Saunders, the CEO of ICMDA, and we're delighted to welcome our speaker, Dr. Mhoira Leng, today, who's going to speak on palliative care of COVID-19 patients in low-resource settings. Now, just before I introduce her, the way this works is that we'll run for an hour altogether. Dr. Leng will speak for about 30 to 40 minutes or so, and then we'll have 20 minutes of questions after that. So let me introduce Dr. Leng to us. Dr. Mhoira Leng is a specialist palliative care physician, currently holding two roles as head of palliative care in Makerere University in Uganda, and also as medical director of Cairdeas International Palliative Care Trust in Scotland. She trained as a doctor and then a physician in internal medicine in Aberdeen University, Scotland, then specialised in palliative medicine, and she's a fellow of the Royal College of Physicians of Edinburgh and of Glasgow. She took up a senior consultant and honorary senior lecturer position at Aberdeen University, initially for 10 years, and then over the last few years has travelled widely throughout the world in 4 different continents with an interest in international palliative care. She's committed to working alongside partners in the developing world to build capacity, offer mentorship, support curriculum development and new models of care. And since 1998, so the last 20 years, she's traveled to Eastern Europe, traveled extensively within India, as well as Africa, where she's currently located, and left the National Health Service in 2005 to allow her to work full-time in international settings. So we're delighted to have you, Dr. Leng. Thank you very much for joining us in your very busy schedule. And let me hand over to you now to speak to us. Thank you.
Okay, so I can't see every one of you who are on there, but I already saw names that I know and people with a lot of expertise. So it's great to be part of this series. I listened to the last 2 webinars and they're really excellent, and I'm going to try and not cover the same ground. I'm delighted to be asked to speak about palliative care, and I am aware that this is a really quite large topic, so I'm going to do a fair bit of signposting for you. So please, you'll get the slides with all the resources. I've tried to signpost to people in different parts of the world. I think this is one epidemic, if you like, or pandemic setting where, in fact, low-income, middle-income, high-income settings are all being affected by COVID-19, and there's a lot of principles and similarities and mutual learning. I wish the machine was working. Okay, so we just have a slight problem with, here we go. Okay, so I'm going to really look at, first of all, the context, outline what I think are the key areas for palliative care interventions, signpost, as I mentioned, and just come back to our humanity in medicine. As I speak, can I ask you to consider downloading this ebook, if not now, then later, and also this app. Now, this app was written by colleagues in Bangalore. It's a very good outline application for adult palliative care. I'll give you some pointers for pediatric palliative care in the resources at the end. But also the ebook has been a fantastic collaboration between ICMDA, Palli-COVID Kerala, and a number of experts to produce a full ebook with algorithms, and will be supported by a webinar series. So if what you would like is more training in palliative care per se, please download that, look at the algorithms, and take it from there. I think most of you will know what palliative care is, but it's an approach to healthcare which is aimed at improving quality of life, reducing suffering, restoring dignity. It has a particular role in people with chronic disease and their families, and those particularly with life-limiting illness. And this diagram kind of tries to give a feel of where palliative care fits in the disease spectrum. It's part of the disease spectrum, as opposed to something that comes after treatment is finished and right at the end of life. It does, of course, include care for the family into the bereavement phase. This is a phrase that has been used initially in Nairobi Hospice, adding life to days, not just days to life. Again, just to set the scene, we have a lot of documentation you'll find in WHO, the World Health Assembly, and so on. There was two very important reports in the last few years. One was the Lancet Commission on Pain and Palliative Care, and the other, the Astana Declaration in Primary Care. If I just take the Lancet for a moment, I want you to look at this map and find yourself on the map. And if you have difficulty finding yourself, it could be that you're in a country with very little access to pain relief, because the size of the country in this map is relative to the amount of access to opioids in particular and pain relief. And that's going to become relevant as we go on to look at a COVID-19 setting, because one of the medications we want to have access to is opioids. And we can see that we're starting with a significant, in fact, I would say one of the most significant health inequalities. Palliative care should be part of universal health care. It should be part of a health system that delivers quality, access, and of course, protects financially. And we know all too well at the moment how health systems are stretched. And thank you to the last webinar, which really outlined the health system implications of COVID-19 extremely well. We've also been describing for some years how palliative care should respond or should be integrated into humanitarian settings. There's a number of documentation, the WHO guideline, FEAR handbook, which is for all humanitarian agencies, now includes chronic disease, end-of-life care. We have some literature and a Lancet article. You can also see something that was photographed live in Nepal at the time of the earthquake. This is a scene from the earthquake by a very good colleague, Dr. Dan Mundy, just showing some of the triage on the ground at the time. And you can raise some questions really about how we do triage, and we'll talk about that later. There's also been some interesting work looking at settings such as the post-Kerala floods, also the Rohingya refugee settlement, and we've been doing work with amazing colleagues in northern Uganda for South Sudanese refugees, and there is more. So we've been trying to establish where does palliative care fit in both the universal healthcare setting, health systems, and humanitarian settings. But I don't suppose any of us imagined quite the scale of this global pandemic. Let me quote from a letter that some of us wrote and was published in the Lancet after a Lancet Palestine Health Alliance meeting, which I think summarizes where we're starting from in palliative care and why it makes so much sense in a Christian healthcare context. It reminds us of mortality and humanity when we're dealing with illness and serious illness, death and dying, with serious health-related suffering. It's rooted in the recognition of our common suffering and our compassionate response. And I think this is very important, our shared humanity. And that's something I want to come back to at the end of our session today. But let me take you on a little journey through an article in the Washington Post very recently. And it was entitled, "All Doctors Are Palliative Care Doctors Now." And I loved it. I think as a specialty, we're here to support what I call generalist palliative care, to get everyone competent and confident at easing suffering, at holistic healthcare, at quality of life. But what she's saying is that they're really being called on in this pandemic to offer solace, to preserve dignity, to deal with and support and minister to, it's a lovely word, the distress of patients. And this is important, looking at existential uncertainty. I wonder how many colleagues day to day are thinking about existential uncertainty. She also goes on to talk about values and priorities. Professor John Wyatt very carefully helped us think through the ethical issues where we must look at appropriate treatments, but we also must apply that to the person in front of us, not in a utilitarian fashion. And that again is emphasized by this young doctor. And she reminds us of something which I think we do need reminding of, that bearing witness and easing suffering is at the heart of medicine. It's the reason why the modern specialty of palliative care came up in the 60s, because of this need to restore this humanity into healthcare. And of course, we see that in other areas, not just in palliative care. I also love that she said there's so much more to be done. Even in situations where we can feel quite helpless in terms of our medical science, there is a huge amount to be done in terms of our medical and clinical humanity, and just in terms of our common humanity. I mentioned another reference on the slide there because this is a surgeon saying very much the same. What is it that surgeons need to know? I think there's been a really interesting increase in people thinking about what is our response to uncertainty and to illness and to suffering at a time such as this. Excellent article published by very good colleagues in the Lancet recently, talked about tsunami of suffering. It's an interesting concept, isn't it? And the figures that I put on the slide were accurate last night, but will not be accurate probably by tomorrow. But the areas I think I'd like to move on to look at are communication and goals of care discussions. Some aspects of symptom control. I'm going to focus on those specific to COVID-19, but of course there's still the symptom control of everyone who has a chronic illness already and who will develop it. So please see the guidelines I mentioned at the beginning and at the end for more information. The holistic care, psychosocial and spiritual. I mentioned about end-of-life care, and then something about supporting staff. And that came out very strongly in the articles I've already quoted. Effective communication. It's a challenge in this current setting. And I think I just want to start by saying that being present is an incredibly important part of communicating. Being actively present, listening, using your verbal skills and what non-verbal skills you have, your body positioning, your eye contact. I have a lovely colleague in Cairdeas who's talking about smiling with your voice. People are pinning photographs to the front of their PPE. We have to work to preserve dignity, to help that person see, even if it's by words that they are seen. Some people are developing cards. You see some emojis, ways in which we can try and smooth that communication, even with the barriers of PPE, to make sure that we are delivering what healthcare we are delivering in whichever setting with empathy and with compassion. And of course, teamwork and creativity. This bottom picture is from Palestine, from Gaza, where some extreme creativity is going into the PPE. So we've got particular challenges for communication. This is relatively unexpected, although in some ways public health has been predicting this. We have isolated and quite desperate patients and families, high levels of anxiety, pre-existing inequality to resources, which is only being exacerbated by the strain on health and social care systems and on governments and international organizations. There's emotion, there's anger, there's fear, there's distrust building that somehow their care will not be prioritized. The stigma is significant for the general population, for those diagnosed with COVID-19. Words like suspect being used, or as virus spreader. These are very stigmatizing, pejorative words. And of course, we have a health system under extreme pressure. I don't have time to take you through all the basics of communication, but to remind you that you probably know some. You probably were taught it before, or you were modeled it. So go back and remind yourselves. Have a look at some of these tools that are around. There's an excellent series called Vital Talk, which are short videos that can help. This is a tool that's been around for a long time, which just helps us in that communication. What is the environment? Have we found out how much that person that we're speaking to knows and what they would like to know? In more communal societies, often these decisions are made along with family members, but remember to also include the patient in that discussion. We need to then give permission to share information before we start giving knowledge. And remember all of your empathetic responses. You're going to have to use your verbal skills, perhaps in a way that you haven't done for a while, because you can't rely on your non-verbal ones so much if you're wearing PPE. Of course, there's many circumstances where you're not going to have full PPE. And please just use these as a way to approach communication. And at the end, we summarize and allow room for discussion and going back. There's another tool in some of the goals of care documents, which you'll find in the ebook, and it's called the nurses tool. I think it might be because nurses are particularly good at this empathetic approach, but it talks about when you see a difficult emotion, acknowledge it and kind of mirror what you're seeing. Give some validation and understanding to what you've seen and heard, and respect. Even if you want to change or challenge what somebody said, start with a position of saying, we're with you, together we want to do the best for you and for your family. And even if there's areas we need to discuss, we'll do that together. And then, of course, ways in which to support the patient and to offer further support, maybe from other team members. Do remember you're part of a team, and sometimes it could be the volunteer, it could be the spiritual caregiver, it could be family members who've been empowered, it could be nursing or social work staff. Now, goals of care discussion. I'm not going to go over the ethical frameworks that Professor John Wyatt explained so well, but I just want to start by saying, have these conversations as early as possible. We know now really very well that patients with significant comorbidities and those with a short life expectancy and those who are older are not going to benefit nearly as much from invasive treatments. In fact, they may be futile. We're also seeing those invasive treatments becoming more focused on non-invasive ventilation, high flow oxygen. It's very difficult to have these conversations in the acute setting. If you have to do it, please do it with all of those principles we've just talked about. But if you can, have those conversations in advance and have very clear triage systems that remind us all that the majority of patients are not going to be ventilated. In fact, those who are ventilated, we're seeing quite poor outcomes even from very high income settings. So triage is not about denying care necessarily. I know some of you are in very resource constrained settings. It may be actually about appropriate care or appropriate care given the circumstances. If you are having to make triage decisions, make sure there's a framework, backup, communication documented, and a support system for you and for the patient. So let me come on to the main symptom complex that we're seeing in advanced disease. So these are particularly patients who've got refractory symptoms who are not going to be moved to a critical care setting. They may be managed in a hospital or a triage setting. They could even be managed at home. That's being less done in low and middle income settings at the moment, but it is being done in high income settings. And there's a particular complex of breathlessness and of agitation or delirium, which is proving quite difficult to manage. And I'm going to focus on that one. Of course, there are many other symptoms. Please look up the guidelines. I mentioned the Scottish ones here. I'm a little biased towards Scotland, but I've also highlighted many other excellent guidelines that will help you anticipate and manage this symptom complex. Remember your non-pharmacological interventions. We are increasingly seeing patients being managed prone in critical care settings, not yet in non-critical care, but it's an interesting issue. We are being asked to avoid fans and AC if they're available. High flow oxygen can be there, but of course it may not be there and it may not be appropriate. The two medications, the two groups of medications you need to have with you in your armament to manage this symptom well are opiates and benzodiazepines. Perhaps you're not comfortable or competent with using these in palliative care settings. There are a lot of guidelines. There are online trainings you can get. I'm showing you the guideline that's been developed in Uganda with my colleagues here. And we've developed this alongside critical care. And this is particularly for those who are going to be actively managed for COVID-19, but managed more from a palliative care perspective because they are triaged for non-invasive management. You need to be able to give these opiates through the oral route if possible, but when the symptoms are more severe, we need to think of the parenteral route. And the parenteral route, which is preferred, is subcutaneous. You get a longer duration of action. You don't have to find an IV line. As I'll show you later on, it can be done in the home context, although many countries don't do that as yet. But this is a challenge because where opiates are available, it's tended to be oral. And we may need to think about subcutaneous use in this setting and be ready for that, particularly in hospital settings, but also thinking beyond that. Some people are using other routes such as rectal, transdermal, sublingual. I'll come on to that. So here's what the ebook that I mentioned will tell you, and you can have a look at that. So for those who are opioid naive, using a low dose of oral morphine or subcutaneous, adding a benzodiazepine if there is anxiety and agitation. And if you think about it, a person who is frightened, breathless, deteriorating is inevitably going to be anxious as well. And so we use either a short-acting benzodiazepine like lorazepam sublingually, or midazolam if we have it subcutaneously. In Uganda, our guidelines say diazepam. The slide before was diazepam because we don't have readily available lorazepam. So look and see what's available. What do you have in terms of benzodiazepines? Not to depress respiration, absolutely not. Low doses for the opiate effect, which is central on the cessation of breathlessness, and the benzodiazepine for the anxiety and agitation. In low dose, titrated, but we may need to be a little brave if we have a very distressed patient, and that's when I advise you to have your guidelines to hand and have done some kind of training specifically on the management of this symptom. I'd be delighted to take any questions at the end of this session. Psychosocial support. A colleague of mine, Dr. Chitra Venkateshwaran, has spoken about this a lot internationally, and I love this term, recognizing and making sense of distress. We have a lot of issues that are going to spark mental health problems. Prior mental health issues, isolation, overwhelming loss and grief, information overload, of course, specific issues like domestic violence, particularly affecting women and children, those who have habitually had challenges with substance use, and our healthcare workers. I think many of you will have seen the documented situations where families have not been allowed to bury their healthcare workers, or even suicides. There is a tsunami of psychosocial distress, and we need to make sure we are aware of that and looking to see how we can support. This is a really excellent algorithm. This is in the ebook. It has do's and don'ts at the bottom. It also has an expanded section outlining what psychosocial or psychoeducation is. But it takes us through very nicely using a scale at the bottom, which is based on the distress thermometer, and another tool from Canada, which helps you just pick up who is at the red end with significant problems that we need to intervene quickly and perhaps even refer, or who can we use our communication skills, can we use our what we call psychoeducation, validating and normalizing, enhancing coping, and maintaining hope. Spiritual care is part of this as well. And of course, we have pharmacological interventions too. It's a lovely algorithm. I suggest you get the whole algorithm with the do's and don'ts and print this out if you want to look at this further. Spiritual support, that core inner part of us that searches for meaning and purpose and connectedness and hope, many of which are being challenged by this pandemic, but are also being facilitated. I think there's a way in which having to look at our mortality, being faced with it, is making people ask these deeper questions. And these are wonderful opportunities to explore these issues, but please do so with gentleness and with skill, offering presence, that being without feeling you have to have all the answers, letting people tell you their story, facilitating that, having questions to open this area up. One of the ones I use is something like, where do you find strength or hope in difficult times? or when you've gone through difficult times before, what has helped you? And that is a kind of positive way of asking the question, and may allow people to talk about their grandchildren, their sense of leaving something behind, of living a good life, or it may take you straight into areas of faith and hope and distress. I also would like to say that we titled this Low Resource. I think in low income settings where managing scarce resources is a daily challenge, where people are faced with mortality for things that are easily remedial, TB, malaria, childhood pneumonia. We may find, in fact, there's resilience, there's a spirituality in some of those settings that our high income settings are only just beginning to face. So it may actually be high community and spiritual resource rather than low resource, high income. Okay, just moving briefly to home care. This is my colleague, Dr. Bijou, who is doing home care. This photograph was taken a day or two back in Kerala. Home care is feasible in the era of COVID-19, but you have to be careful. You have to look at your basic care and infection management, whether or not you're having areas of your home care and of your hospital setting set aside for COVID-19 positive and non-positive. Although we know so many are asymptomatic, we should actually be taking precautions. PPE is controversial, it's not always available. Please try and see what is available and make sure that you use the social distancing, the hand hygiene. You can see here hygiene being done at the patient's home. And let's also use these home visits as an opportunity to address stigma. The WHO resources are excellent, and I draw your attention to these. The more rural the setting, the more challenging this may be. In Kerala, the ASHA volunteers are involved. In Uganda, the community health workers are involved. Look and see what in your health system can be mobilized. When we're doing home care, we do need to remember to empower and train family caregivers, if at all appropriate. I just show you here subcutaneous delivery being done in an Indian context. There's also an RCT showing its use in a number of international settings. It's a little controversial. In Uganda, it's not something that's commonly practiced. In parts of India, it's very commonly practiced. If Dr. Stanley McAdam's on the call, I know this is something you pioneered in Bangalore Baptist Hospital. But we do need to think of whether we can give oral medications rectally, which can be problematic, but maybe our last resort, or can we use the sublingual route? In high-income settings, transdermal is being looked at as an option for less contact, or less contact that might break that distancing barrier. This is a challenge. It's a real challenge, particularly when it begins to affect the very rituals of grieving and loss. I just want to tell you that my neighbour here, her mum died recently, and the two things that she's remembering, she was a continent away, is the WhatsApp call that they had with all the family members speaking to their mum. Just one sentence her mum spoke to them. And the second was the paragraph, I think about 2 sentences, that the caring nurse sent to her to tell her what her mum's last moments were like. There's ways in which we can really work with people, even if it's delegating to psychosocial team to share those communications, even if it's using existing networks, mostly virtually. Our team here in the hospital in Uganda are mostly doing virtual support, but they're doing a really good job in that space. And please, let's remember our vulnerable populations. This won an award. I don't know if you saw this picture the other day, won an award. It's Rohingya children lining up for food. The social consequences, particularly for children, are huge. I'm in a country just now which is one of the youngest in the world, Uganda, and most of the lockdown process, of course, are protect the vulnerable and the elderly and those with comorbidities. But what effect is it having on the young, particularly in their access to health? We're seeing that all over the world, that access to health has reduced. And in lockdown, in low-income settings, this is hyper-acute and very, very difficult. Prisoners, those who are in particularly vulnerable situations, the homeless. But just a picture to show that some things are actually happening. This is a refugee camp in northern Uganda, and I'm very impressed by the social distancing they've managed here as people are collecting their food, quite different to the photo on the left. And then touching on end-of-life care. Symptoms of end-of-life care, please look up in those links I've given you. But this is I found this a very moving picture of someone in an intensive care or hospital setting, but not alone, not abandoned. And we've talked already about those opportunities to say goodbye, not having the situation described in this headline where this young Zimbabwean journalist, the first person to die in Zimbabwe of COVID-19, described himself as alone and scared, no symptom control, and no one present. I'm not going to go back over the ethics because that was covered well, but I'll draw your attention to these series of briefing notes, this one on ethical principles being produced by some of the key global palliative care organizations. And I like the fact the very first ethical principle they've actually put here is non-abandonment. They also have put the issue of reciprocity. You know, one of the things that faith-based organizations, Christians, have been known for over the years is fighting for justice on behalf of the vulnerable, the oppressed, those without access to basic healthcare. But please also remember our colleagues in that, so that we seek for a just and a fair health system, and we seek to protect and to look after our colleagues, as well as, of course, our patients and families. It's all part of the same care circle. And so I come on to staff support. I've been hearing a lot about the need to sacrifice, to go above and beyond, and of course that is our day-to-day calling in healthcare. But can I also say we need to care for each other? We need to see what the Lord himself tells us about being restored, about times of quiet, which he also modeled for us, even in the midst of huge crowds seeking his help. We need to try and ensure that the environment is as safe as possible for staff and for patients. And we need to give permission for staff to also need and get spiritual and psychosocial support. We need to think about the issues of burnout and compassion fatigue and moral distress, where people are finding they're making decisions, maybe based on resources or settings which are out of keeping with their values. And that's very painful and can lead to quite significant spirals of burnout. Vicky, in this bottom picture, is a lovely colleague and dear friend who works in northern Uganda, in an area with high number of refugees and a very rural population. She was interviewed because they had the first COVID-19 patient admitted and then discharged from their district hospital recently. And she talks here very movingly about protecting oneself. She's leading the psychosocial interventions. She's talking about self-care, and she's combining that with a real sense of God's calling. I am doing God's work. So doing God's work does not mean we don't also care for the humanity in ourselves, even as we're caring for the humanity in the patient and the family in front of us. So as I finish, I want to use this term that was said by a gal, a medical student I was teaching last year. We were asking them what palliative care meant to them as undergraduate medical students. And this young lad said, humanity until infinity. Sounds like a superhero call, but it's made me think a lot. What does that mean in a context like Gaza, where the lockdown has been 11 years, not a matter of weeks? We need to make sure we are engaged in compassionate, holistic care, focused on the family. We need to integrate that, have a health systems approach. We need to access training. And by the way, if you haven't had palliative care integrated, please do going forward. If this has underlined anything, it shows that we need to do this. Adopt and adapt guidelines, contact your experts, engage with community leaders and faith organizations. Make sure you've got the medicines and ideally the safe working conditions. I won't read all of this, it's quite a long article, but it was written by a New York emergency physician in discussion with an Italian emergency physician. And you can see the journey they went on, with the Italian colleague saying, I'm almost needing to distance myself to stop feeling human. And the New York physician saying, I'm used to doing everything. I'm used to pushing mortality to the edge. I've never felt more useless. That sense of helplessness, that's a transition that many people working in palliative care go through. But they're both coming to the conclusion that it is our humanity, is to be a person first, is one of the greatest needs of our patients and families and of ourselves as healthcare workers. And so I finished with what I found a very beautiful meditation. I've been involved in a meditative practice during this time. And this meditation, I want to read it for you and to think of how we can be these candles. We have to be candles burning between hope and despair, faith and doubt, life and death, all the opposites. This is the disquieting place where people must always find us. And if our life means anything, if what we are goes beyond the walls and does some good, it is that somehow by being here at peace, we help the world cope with what it cannot understand. I thank all of you for being candles in your setting, for bringing that hope and peace into your setting. And I also hope that you will be able to take some of the skills and knowledge of palliative care to support your colleagues, your patients and your families as together we face this pandemic. But we hold that place of hope and certainty because that is the God-given image in each one of us. And it's to him that we come to for hope, for certainty, even in the midst of difficulty and fear. Thank you very much.
Thank you very much, Mhoira. That was absolutely brilliant, incredibly comprehensive. I don't know how you managed to pack so much good medicine, spirituality, compassion into such a short talk. So we're very grateful for you sharing from your experience. So if we just pick up first of all, Mhoira, right at the end, and you came back to your own personal testimony of how you reach or deal with this as a Christian. The question that was up there first was, how can our life in Christ influence the lives we're catering for in palliative care units? And perhaps to share a little bit of your own experience there.
I think you can't work in palliative care. And by the way, can I just say again, palliative care is something that we all do. When we're working with patients with these kinds of issues, it does make us think about our own spiritual health. So I found it over the years an incredibly challenging, but also incredibly rich area to work in, because it continually makes me come back to say, where is my spiritual nourishment coming from? Am I trying to do this in my own strength, with my own words and my own medical skills? Or am I coming to the feet of Jesus to see in him a compassionate, caring, holistic person, and to actually find grace and hope and mercy in my time of need? So that, you know, that lovely verse in Corinthians talks about comfort coming into our lives and pouring out again. So I say to everyone, whatever faith background, be spiritually healthy and think of what that means. For me, of course, that's rooted and grounded in the person of Jesus and in the wonderful knowledge that his resources are limitless.
Thank you. There's a question here. People are saying in many cases of COVID-19 patients dying in the hospital isolation room without any family, with very limited time with doctors and nurses even. How do we start palliative care to the patient in these situations where perhaps the focus might even be on more intensive treatment, and how do we focus on the family and best serve them?
Absolutely. So I think there's a number of elements to that. It's tough. It's tough. I've seen some settings which are setting up, and we're trying to do this here, psychosocial support team, so that the busy medical team can refer to the psychosocial support team, of which palliative care can be a core component. There are other psychosocial care providers, so that those conversations with the family and support can be happening even as the frontline medical staff are doing their roles. There's also ways in which we can use some of these virtual communication tools, particularly as people are scattered. But please don't also underestimate the moment where, with your full PPE on, if you're in that setting, you just take that moment to acknowledge the person that is there. So I think it's a combination of that verbal and non-verbal skills we talked about, I really think we need to devolve some of these psychosocial and spiritual supports away from the critical care doctor, so that they may have the first conversation, but perhaps all the backup and follow-on conversations they can be supported in. And please have those conversations before people get to critical care, if at all possible. I don't know many churches and faith-based groups that are getting involved, but I don't see any reason why not. You'll be part of that psychosocial support, but be skilled in doing that in a way that you listen rather than impose. But you have to be quite careful about that. These are vulnerable patients.
So many of us as healthcare workers are geared into healing, wanting to make people better. And often we can see a patient's death as a failure. What would you say to people who are finding themselves, perhaps even now, in that position?
So I would say it's tough. Be kind to yourself. Many a healthcare worker has gone through that barrier. I quoted some in the presentation. Actually, most of what we do in healthcare is hold those places of uncertainty in chronic disease. That's why I came into palliative care. I realized I wasn't doing this very well. And so I wanted to have the skills to get away from a more saving everyone to a caring for people and acknowledging suffering and seeing what I can possibly do to medically alleviate that. I must do that, but also doing that in a holistic way. So this is a normal emotion you're going through. Don't feel you're failing as a doctor, but you're going to have to build in your holistic care for yourself and for your patients, and you're going to have to hold that place of uncertainty. And remember that life and death are not in our hands. We have an incredibly privileged role as healthcare workers, but life and death are actually in God's hands.
Now, you touched on the whole area of spiritual histories and opening up questions and conversations delicately. And I loved your question, where do you find strength or hope in difficult times, I think you said. But can you give some advice about taking spiritual histories, understanding where patients are at in order to focus our conversation in the right kind of places and meet the needs?
Sure. I think it's one of my favorite parts of a clinical history, and like every other part of a clinical history, it's going to tell you a phenomenal amount that you're going to need to do your care well. But it's not something we teach too often. What I say to people when they're looking at this is have some thinking around the components of spirituality, allow open questions, and then listen and probe. A colleague did some lovely work here in Uganda showing how telling your story, the narrative, is very important. So what are you proud of in life? What do you feel is your legacy in life? What things do you want to pass on to the next generation? Are there people or situations where you need to know forgiveness, where you need to complete business? Do you need to make a will? These are all part and parcel of conversations, but those start with, I think, something to open up coping. And the one I like is that positive one. I like to ask people about their sources of hope and strength, because then maybe I'm going to learn a lot about them and not put it in a problem to start with, have it more open, and then I'll use my skills to probe. Remember that connectedness is very crucial in our sense of belonging, our reconciliation to the Lord. That's one of the key parts of our faith. We are isolating people, we're disconnecting people, so we need to find ways to reconnect, if at all possible.
It's a great set of questions there. Someone saying here, just commenting a more practical thing about opiate supplies, can you recommend a practical way how we can solve the problem of the shortage of opioids in resource-poor settings?
So I would say that I've spent most of the last 30 years of my career engaged in this, and many others have. It's not a problem we've solved yet. There are, however, ways in which progress has been made. So I would suggest go to the resources pages. I've linked to all the national associations and the key global ones. There is quite a lot of advice there about how we can follow that up. There are some global bodies, particularly the Narcotics Board and WHO, who are trying to make sure essential medicines are there. They are on the essential medicines list for WHO. So contact your health system people. If you're a policymaker, look at this actively. If you're not, you may have to compromise. You may have to use what you've got. Tramadol, other benzodiazepines. I mentioned diazepam that we use here. You may have to speak to your colleagues in psychiatry about the antipsychotics that could have a use as sedatives. So be imaginative, but get engaged now at accessing this, and please be part of making a difference to that map in the future.
Now, you've touched on the whole issue of families and people dying abandoned and alone, and families not being able to relate with them. Is it possible to get PPE to families for those visits? And have you had any experience in that situation where someone is obviously dying and in their last hours or days, finding a way for the family to connect with them? More personally.
I mean, I think one thing I possibly didn't emphasize enough is that, of course, there's so many people that are needing healthcare who don't have COVID-19, and a lot of our work's going to be there. What I've seen thus far in the lower and middle income settings, because in fact that's not where the major pandemic is rolling out at the moment. What I've seen is very innovative use of telephone, and if possible, smartphones. Smartphones are not widely available. I've also seen people making locally sourced masks, a lot of controversy about that. I think if the social distancing and hygiene is emphasised, there's ways in which we can use appropriate coverings in a local setting. We have found, for example, in Uganda, a supplier that the palliative care stakeholder community has then sent out to include family members. So it's tough. I do think that there's a lot that we can do in the circumstances we're in, as well as link in and engage with what's happening at a health system level.
Would you like to comment a little, Dr. Leng, on the role of the churches in this? Because we have a huge army of volunteers with resources, and perhaps give us some examples that you've seen in resource poor settings.
Well, I'll give you a good example in the church that I'm part of here in Uganda. Some years ago, actually recognised this was an important area, and we have developed a palliative care volunteer team. So they're trained, they're skilled, they're not healthcare workers, and they already do a fantastic job. And they have the confidence of the healthcare leaders, the directors of the hospital and the community, because they're well trained. So they're trained in how to care for people of the same faith and of other settings. I would say this is a fabulous moment to really engage with this tsunami of suffering, to have that core of hope and fear, to care for the church community, but as a church community to reach out beyond to those who are in need, and to do that with a lot of gentleness, a lot of grace, and a lot of hope, holding those places with people. Do that through whichever way you can do it. I've seen people doing FaceTime interactions, telephoning, delivering food and essential needs to families that they know are vulnerable, being known as the place that people can come to if they're vulnerable. And some of you also can take on some of these trainings and get involved working with your local healthcare teams to provide that holistic support. So churches, faith-based organizations, this is an amazing opportunity to really demonstrate the love of God in action. And please do that as part and parcel of this response, this holistic response.
Someone's telling the story here of a sad case of a mother who was nursed at home, and then as a result of that, 2 of her adult children contracted COVID and died themselves. So this question, how can palliative care be done safely for other family members in the home environment?
Yes, if you look at that WHO guideline, it's quite helpful. It does take you through step by step. It doesn't negate the risk at all, and we have to balance family members' risks. I saw a lovely example in Malawi where a village had got together and decided to segregate the older and the younger people, but the younger people were looking after the older people, but with social distancing, food and so on. So try and get the community you're in to come up with viable answers. They set up the ASHA system of delivering food. If there are family caregivers who are there, do give them information about hygiene, about how to look after the person who is alive, but also how to manage a dead body, and talk to them about PPE. Use the guidelines that are there. I think it is possible. I think it is happening, particularly those with mild disease. It is also happening, for example, in London, people are being discharged home for end-of-life care, with the palliative care mostly virtual, supporting the family carers. But please let us help protect each other and our family members, because this is a really difficult time when people are dying of the same illnesses in the same family. That's really tough.
From your experience, what are the most common anxieties and worries that people express at the end of life, and any tips on handling those in addition to what you've said?
Yeah, I mean, I think anxiety for sure. And even for those who have a sure and certain hope and faith, there can be an anxiety about the process, what's going to happen. Definitely a sense of needing to know they're not going to be abandoned. That sense of we have to go through that final journey alone. As Christians, we believe that Christ is right there walking beside us. But we can still have that sense of not being left alone. I feel as though some of those who are at high risk are being given the message, we're okay, you guys, sorry, you're high risk. And they're beginning to feel that sense of abandonment even before they're diagnosed. So the skill of listening, skill of not prejudging, of letting someone tell you, people may also tell you things that are actually very enriching. When I ask people what gives you hope, I'm quite often encouraged by that. And we can sometimes discuss even verses of scripture that have encouraged them. So I think the key is listening, and the key is opening that skilled opening of those areas. But let's particularly remember distress, anxiety, and that feeling of abandonment.
Now, you said quite a lot about caring for the carers and how important that was and how often it's neglected. Turning the same question, what are the main anxieties that you've seen in healthcare workers caring for people in the context of this pandemic, and how can we lift up and help one another with those things?
I think they're significant, and I think I would be concerned, and I just want to gently challenge those of us working in faith-based contexts, that we have this narrative of sacrifice, and of course that is core part of our faith. But let us be careful not to pressurize people into feeling it's actually a response to complex trauma, that they themselves are not important. I think it's actually both. It's that sense of mutual humanity we must work on. Vicky, when she was interviewed, her husband said, "Are you going to bring COVID home now?" They had to set up separate sleeping arrangements. She had to sort of think through the implications. But I read a very, very good quote from Liberia recently. It was written by someone who'd been involved in Ebola, saying we were too quick to dive in there without PPE. And actually that just meant the next person was less skilled than you, that was having to do your role when you became sick and perhaps died. So let us get that balance between rest and restoration. There's a little bit of evidence in Italy that the most exhausted, the heroes, if you like, were those who also maybe succumbed. So let us get those balances there if at all possible, and support people to make sensible decisions about their living arrangements. People are being chased out of accommodation. Let's find ways to feed and house and support our healthcare workers and help them make those decisions personal to their family setting, and not pressurize people into making decisions that are not right for them.
Yes, and as you say, if we don't look after ourselves, we're not there to provide the care, and it may well mean that others who don't have the same skills are thrust into the limelight. Well, we've just about run out of time. I don't know, Dr. Leng, if you have any final word for people out of the many rich things that you've already shared that you'd just like to say at this point before we draw things to a close.
Just to say, it's a privilege to be healthcare workers at this time. We've all got a different role and purpose to contribute, and I wish you well. We are in this amazing place of being, as I go back to that image of candles, holding those places of uncertainty. Thank you to each of you for what you're doing. And together, I think this is going to change the face of healthcare, as well as the face of many of our societies, as we tackle with these really deep and meaningful issues, and as we hopefully find God at the centre of that.
And that's a great place to end, with God right at the centre of it. Thank you so much for the way in which you've spoken to us today, all the insights you've shared. Thank you again, Dr. Leng.
Pleasure.